Modification, it's one of the nightmares that every cardiologist have. Three beautiful talks, three beautiful experts who have used it, and they are the masters of the technology. We know Dr. Prakashveer Parikh, sir, who's been probably the pioneer of rotablation in our part of the world. Professor Mamas Mamas, big an IVL guy, and orbital atherectomy, very rarely used. Tejas V. Patel was part of that trial series. So this is, for this session, I would like to invite Dr. Kushal Pujara, Dr. Pratik Rawal, Dr. Tejas Shah, Dr. Neerav Shah, Dr. Varun Sibal, Dr. Hemal Thakkar, and Dr. Pankaj Singh as our chairpersons and moderator. Introduce our speaker, case, show in case the case, this is the case, and how do you actually do plaque modification. Speakers and chairpersons on the dais, please.
Good morning, everyone. So, presenting this case, it's a 55-year-old male who has unstable angina with 95% calcified long LED lesion with TIMI2 flow with resting ST depression and deep T wave inversion on ECG changes in anterior leads with left ventricular ejection fraction of 55% with negative biomarkers and positive myocardial perfusion scan for ischemia at low workload in the LED territory. Best strategy for the plaque modification would be, and the learning objectives would be to differentiate between IVL and atherectomy, indications of orbital versus rotational atherectomy, and techniques and practices of plaque modification. I would like to invite as first speaker, Dr. Prakashveer Parikh, sir.
Good morning, friends. So, in this session, we are going to discuss about the management of heavily calcified lesions in general. So, I'm going to speak of the rotational atherectomy, which is the very old device, but still no competition so far. It's the most effective device to treat the heavily calcified lesions. So, calcified lesions are difficult to treat. There are several challenges. First, it's difficult to advance your balloon to dilate. Even if you are able to advance your balloon and cross the lesion, it's difficult to dilate it completely with the full opening of the balloon. Even if you can dilate with the full opening of the balloon, it's always difficult to deliver the stent and expand the stent properly. And in turn, this procedure is always complicated, so associated with a higher complication rate, with higher incidence of perforation, dissection, balloon rupture. And many times, whatever you do, you don't get the optimal procedure results. So we result in bad long-term and acute results like you have higher stent thrombosis and restenosis in future. So it's always challenging to the heavily calcified lesions, and calcium is a very major determinant of the stent under expansion. So adequate lesion preparation is a key for the optimal stent expansion. So how do you treat the calcium? In general, there are several calcium modification devices, but basically there are only two ways to treat the calcified lesion. One is to crack the calcium, and second is volume reduction. Cracking the calcium means you create a crack with the balloon-based technology, mainly the scoring balloons or modified balloons like cutting balloon, angiosculpt, and the newer device is, of course, intraocular lithotripsy, which is based for creating the multiple cracks in the calcified lesions. But just creating cracks is not sufficient for the most of the heavily calcified lesions. And you need to debulk the lesion. Means volume reduction of the calcium is very, very important. In that, category, we have a ablative technique like rotational atherectomy and orbital atherectomy, which are very important tools to reduce the volume of the calcium. So basically we have two kind of technology, balloon-based techniques and ablative techniques. Balloon-based techniques involves a non-compliant balloon, super high pressure open NC balloon which can go up to 40 atmosphere pressure, then scoring balloon in which you have Scoreflex NC, Wolverine cutting balloon, angiosculps, NSC apata balloon, and intravascular lithotripsy. The balloon-based techniques, they do not remove the calcium, but they improve the plaque elasticity by the creating cracks in calcium, which will facilitate greater stent expansion. The advantage of balloon-based techniques, they are user-friendly. You don't require special training to use those devices. But they are effective only for mild to moderate calcium, except the IVL, which is effective for the heavily calcified lesions also. While the ablative techniques in general includes the rotational atherectomy, new addition is orbital atherectomy, and excimer laser. Atherectomy is effective for creating cracks in the calcium. It will ablate or shave the calcium, so making it more thin. So this thin calcium can be easily modified by subsequent balloon dilatation. They have very great efficacy in treating the heavily calcified lesions, while the laser fragments the calcium by photomechanical effect. These are three main devices. Rotational atherectomy. It is very important to recognize that rotational atherectomy, there are diamond chips on the bar, which is elliptical bar, and this bar is at the tip of the catheter. The ablative device is the tip. While in orbital atherectomy, this is the tip of the catheter, and the crown is about 6 meters behind the tip of the catheter. So the ablative surface is not at the tip. So that's a very important point to remember. And the latest addition is lithotripsy balloon, in which there is low pressure balloon inflation to oppose the balloon to the vessel wall. And the generator introduces electric charge, which will produce sonic waves to the pressure of creating almost 50 or 60 atmosphere pressure in the artery that is transmitted through the balloon, and that is excellent device to modify the calcium in the vessel wall. Intravascular lithotripsy is a transformative technology. It's a very short learning curve, and it's a unique technology because it is able to treat the both superficial as well as the deep calcium. But unfortunately, it's very expensive, so we can't use in all the patients. So we have so many devices. So how to select the appropriate device for the lesion preparations? For that, we need to have a few guidelines, like we need to know the calcium burden, its location, distribution, and its morphology. So to assess the calcium burden is, what is the calcium mark? It is 90 degree, 180, 270 or more than 270. The thickness of the calcium and length of the calcium. The location of calcium is also very important, is superficial or deep. Distribution, whether it is concentric or eccentric. And the morphology, whether it is calcified nodule or not. So how do you assess the calcium? We can assess by the angiography, and more specifically, to be specific, we can use intraocular imaging like IVUS OCT to define the calcium burden and morphology. Angiography often underestimates the calcification. Now often is when the calcium is even severe, sometimes you will see on angiography it looks only mild or moderate calcium. So it is less sensitive device to detect the degree of calcium. The moderate calcium typically looks like is seen during the cardiac motion only, usually only on the one side of the lumen during angiography. While the severe calcification will be seen even on the still frame without cardiac motion, usually is on the both sides of the lumen, so it is typical calm capitans. IVUS is more sensitive device and more specific than angiography. It provides the information about the location, distribution, calcium mark, and the length. However, IVUS cannot penetrate the calcium. Hence, one cannot measure the thickness of the calcium. In IVUS, typically use the calcium as a bright echoes with acoustic shadowing. OCT is more accurate than IVUS for quantitative calcium assessment because it can penetrate calcium, which allows us assessment of thickness, which is very, very important. Thickness of the calcium is very important to select the device. And of course, it gives idea about the area and volume of the calcium. However, it is a limited depth penetration, So it is poor in detecting deep calcium. So there are when calcium scores have been developed to predict the stent expansion, which includes the criteria of calcium arc length is less than 90 is considered mild, 90 to 1 is 1 point, and more than 1 is severe. And the calcium thickness is less than 5 meters, less severe, is more than 5 meter, then is got 1 point. And the length of the calcium lesion, if it is less than 5 meter, is 0 point, and more than 5 meter length of the calcium is 1 point. So the higher the score, the more likely that you will use special ablative techniques or IVL to treat these lesions. And the scoring balloons will not be effective if the score is very high. So there are various algorithms based on imaging and angiography assessment of the calcium. So when the calcium is mild to moderate, your conventional non-common balloon or scoring balloon will suffice. But then when the calcium is severe, based on the calcium thickness more than 5 meter, calcium arc more than 2 centimeter, and length of the calcium more than 5 meter, they require special techniques like atherectomy or intravascular lithotripsy or laser. So this is one of the latest algorithm for device selection for severe calcified lesion. The first step is you try to cross the calcified lesion with your imaging catheter. If you cannot cross with imaging catheter, or even a low profile balloon or macro catheter, that means you have to have a uncrossable lesion, so you have to use the ablative rotational atherectomy, which is the best device for uncrossable lesions. If you can cross the lesion with the device, with the imaging catheter, and if then you find a calcified nodule, then again you need a atherectomy, either rotational atherectomy or ablative atherectomy. And imagine if you don't find calcified nodule, then your catheter is inside the intimal space, then rotational atherectomy is the device you can use, and of course, then you can use IBL also in ablative atherectomy. But if you are subintimal, then if you want to treat the subintimal calcium, the rotational atherectomy is the only device which you can use. If the patient has instant restenosis with underexpansion of stent due to underlying calcium, then the best device to use will be intravascular lithotripsy. But if it doesn't work because of sometimes you have 2 layers of stent or a lot of fibrosis, then IVL will not work for under ISR cases. So in those cases, you can use laser atherectomy with contrast, or you can use ultra high pressure balloon like OP and NC balloon, or you can ablate the stent with rotational atherectomy. If calcium lesion is very tortuous and angulated, then the safest device used to do IVL. So the current patient has a long calcified 90% lesion with a TIMI 2 flow. In this patient, you have 3 options. So how do you select my device? First is whether the device will be able to cross the lesion or not. Secondly, whether it will efficiently create the cracks in the lesion or not. And third is whether it will reduce the volume or calcium or not. So in my opinion, rotational atherectomy is the best device because of the excellent crossability. It is very efficient in creating massive cracks and is very effective in creating volume reduction. While IVL will not be able to cross such a tight lesions. Even your routine conventional small low pressure balloon will not be able to cross these calcified lesions. The IVL has got many disadvantages like the size limitation, only one lens is available. So when you're treating a long lesion, you may require to use more than 1 balloon, so it becomes very, very expensive. And the number of pulses we can use in IVL balloon is only 80, and the new generation will only 120 pulse. So a long lesion, you will require probably 2 balloons, so IVL is not a good idea to use when you have very tight lesions and very long lesion. Similarly, orbital atherectomy is not the best device to cross the uncrossable calcified lesion because this ablative surface, the crown, is offset from the nosconum device. It was 6 meters proximal to the tip of the catheter. So it will not be able to cross in extremely tight lesions. Secondly, when you use orbital atherectomy, you require a long time if you want to treat the long lesion because the recommended maximum time of one run is 30 seconds. Now after each run, you have to give rest time for at least 30 seconds. And you have to advance the orbital atherectomy catheter very slowly, only 1 meter a second. So if you have a long lesion to treat, the orbital atherectomy will take a long time. So it is most suitable for the focal intermediate lesion in large vessel and for treating the calcified nodule. So in my opinion, rotational atherectomy is the most reliable device for plaque modification, calcium ablation, and calcified lesion preparation. Currently, no other technology can match rotameter as far as the treatment of severe obstruction of heavily calcified lesion is concerned. Thank you.
Thank you, Dr. Prakashwari sir. Uh, as we know, the calcium is the enemy of the intervention cardiologist. You have outlined very nicely, step by step, which device to be used. So I think now we will invite Professor Mamas. Mamas, I think is online lecture for him.
Hi, my name is Mamas Mamas. I'm the Professor of Cardiology, and I'd like to thank Kamal Sharma for inviting me to Cardiocon yet again. I think it's a great meeting, and congratulations. I'm really looking forward to this debate. So over the next 10 minutes or so, I hope to persuade you that IVL is a game changer with minimal risks. I'd also like to acknowledge my two proponents, Dr. Parekh and Dr. Patel, both very experienced interventional cardiologists, and I'm very honoured to share the stage with them. I have no conflicts of interest. And so the case. So this is a case of a patient with a long LAD lesion, impaired flow, that is calcified. And so really for this discussion, this debate, we need to ask ourselves several questions. I think the first question is calcium important in this patient? Why are we even having this debate? The second question that we need to ask ourselves is whether we need any other information about, number one, whether we should even use calcium modification in this case, and secondly, which ones, because there's no point having debate about which is better if we don't actually need to use them. Number three is to ask, well, okay, in these sorts of cases with calcified lesions, what is everybody else doing? I think the crux of any discussion is, do we have comparative data? And then finally, my take-home messages. So, first question, is calcium important in this patient? Is this debate even relevant? And the answer, of course, is yes. I mean, there are literally hundreds of papers. This is one such paper. This is a pooled analysis from the Horizons AMI and Acuity paper from Greg Stone. And you can see that as calcium severity progresses, there is an increased risk of death, cardiac death, MI, stent thrombosis, target lesion, revascularization, and MACE. And you can see in terms of imaging information, you can see that MLD is much lower. You can see that residual degree of stenosis is much higher. Acute gain is much less when you have very calcified lesions, which is effectively what is driving these adverse outcomes. Do we need any other information about whether we should use calcium modification tools and which ones? And I would argue, yes. I don't think that even just by looking at the angiogram, one can decide what you should use. And the reason being that we have very good old data from Gary Mintz showing that visual assessment of angiography in terms of severity of calcium is a very poor discriminator. And we all know there are many cases where you look and see that there's calcification, you think, I'm going to have to rotablate, you do imaging, and actually the calcification is not as severe as you think. And so really, you know, this sort of case you need to image, and this is mandatory to define the anatomy of the calcium, to decide whether you need to treat the calcium and how. Decide whether the treatment of calcium has been successful, and to optimize the PCI and assess the PCI results. And the sorts of information that we get from imaging is the type of calcium, whether it's nodular, non-nodular, the type of nodular calcium, the location of the calcium, whether it's superficial, deep, eccentric, concentric, thickness, the distribution, the angle, and the calcium length. And we have imaging criteria, both OCT, this is data from Akiko Mahara and her group, with imaging criteria including calcium angle, maximal calcium thickness, and calcium length. And so anything with an angle of greater than 180 and thickness of greater than 5 and the length of greater than 5 millimeters, you probably should use a device that will treat the calcium, help you treat the calcium. And we also have similar IVUS criteria, and again, similar sorts of criteria. So calcium that's concentric, greater than 270 millimeters, greater than 5 millimeters in length, whether a nodule is present in small vessel, and if you see a reverberation arc, having these features, again, suggests that you should be using these devices. And this is one algorithm. I mean, there's many. This is from Neves Gonzalo, the director of PCR, and you can see that it's important to think about whether the calcium is eccentric, concentric, or nodular. But certainly, if the arc's less than 180, if the thickness is less than 0.5 and the length is less than 5 millimeters, you probably don't need one of these devices. Cutting balloons or non-compliant balloons are adequate. So what's everybody else doing in these sorts of cases? Well, this is data from the UK. This is data that I showed last year in my role as the national data lead in the United Kingdom. And you can see that rotor ablation, we don't have many cases of orbital atherectomy. That's just starting in the UK, have declined over time. So you can see in the whole of the UK, only 1,600 rotor ablation cases and around 98,000 PCIs, whereas lithotripsy has increased markedly, 2,500 cases on a background of 7,000 cutting balloon cases. And these are the individual centers, and you can see that there's variation usage of lithotripsy amongst different centers, but consistently rotational atherectomy is used much less commonly. One of the reasons that's driving this is that very much, unless you're doing a lot of rotational atherectomy cases, your outcomes tend to be compromised. This is data from my group showing very much that there is a volume outcome relationship in the volume of cases that you do with RA, or it could easily be orbital atherectomy, and in hospital MACE. The less you do, the worse your outcomes are in terms of MACE. And we know that there are no such outcome relationships with lithotripsy. It's literally you place a balloon where the calcium is, you press a button, hey presto, you've delivered your treatment. So I think that's one of the things that we need to think about, ease of use. Yes, there are many experienced people, and I'm sure the protagonists are very experienced, but many operators simply don't do enough cases to get optimal results, and lithotripsy is probably better in these operators. Do we have comparative data, treatment A versus treatment B? And the answer is yes, we have a randomized control trial, the RotaShot trial, a small trial, 70 patients that were randomized either to undergo IVL or rotational atherectomy. We don't have a trial with orbital in these patients. And the primary endpoint was minimal stent area. And you can see there was no significant differences between the two arms, slightly bigger MSA with the rotational atherectomy. This was not significant, and IVL was found to be non-inferior. When you looked at OCT analysis and a whole load of things, everything from stent expansion, stent strut fractures present, tissue prolapse, minimum luminal area, maximum luminal area, mean stent diameter, mean stent area, exactly the same. So we can say that when used, both have very similar outcomes. In the United States, again, we're seeing very similar findings in that, irrespective of whether the lithotripsy tends to have overtaken either orbital atherectomy or rotational atherectomy, as you can see in this figure. But the important thing to say is a significant proportion of cases use both types of techniques. And so I don't think it's helpful in these discussions to say, I would only use orbital atherectomy, or I would only use rotablation, or I would only use IVL. The chances are that you may need a combination of these, either RA or OA with IVL in many of the cases that we do. And again, you can see that in terms of MACE, whether they looked at the whole cohort or the trial-like subgroup, absolutely no difference in outcomes, and again, no difference in procedural success between the techniques. There's a lot of observational data that's been published. My problem with this, where they've compared rotational atherectomy or orbital atherectomy versus IVL, is that there's always selection bias in the studies and publication bias. The patients are often not matched, and most of them are single center analyses, and many of the analyses don't actually account for either the extent or the distribution of calcium. So they can't really be seen in terms of providing information about efficacy. I also think that many of these observational series depend on operator experience. And as I've shown before, a low volume operator using rotablation or orbital atherectomy is going to have very different outcomes to a high volume operator, although this is not present when using IVL. And it's also not really clear how many of these outcomes were ascertained. I think the vast majority of observational studies from good groups have shown very similar outcomes in either comparisons of rotational or orbital atherectomy versus IVL. So in my view, here are the take-home messages. I think the debate is artificial. You certainly can't and shouldn't decide whether you should use a calcium modification device and what type of device to use without imaging. So from the description of the case, it may be more appropriate to use orbital atherectomy. It may be more appropriate to use rotational. It may be more appropriate to use IVL. It may be more appropriate to use nothing at all. You simply don't know unless you do imaging. Every case where you're thinking about using these devices, don't take them out, do imaging first, use the most appropriate device. I think IVL is less operator dependent. It's certainly the most commonly used device in several international registries. It's good for focal concentric or deep calcium, not so good for long lesions. And I think that most experienced operators, and I'm sure my colleagues in this debate, will use multiple devices. I think really the take-home message that I would like to leave with the audience is that really it's not about the best device. There is no such thing as the best device. It's rather the best device for the case in hand that is informed by imaging. So with that, I'd like to thank you for inviting me. It's always a pleasure to interact with Indian physicians. I always have great regard for you all, and I always look forward to coming back and visiting you in India, so thank you.
I would like to invite our third speaker, Dr. Tejas Patel. He's speaking about orbital atherectomy on this case.
Good afternoon, everyone. It's always difficult to debate with two of the giant, very senior cardiologists of our field. Obviously, Dr. PKP sir and Dr. Mamas both are having huge experience of doing all this stuff, and I think Dr. PKP is one of the pioneer of doing all complex interventions and cheap interventions. So as Kamal Bhai said that he is very fond of AI tools. So I thought, let me try with ChatGTP AI tools that how to do debates. I think how to do debates with that. I think this slide is missing. And the answer of the ChatGTP was that you can't. So now I am in trouble. I can't say no to Kamal Bhai that I can't do debate of that. But then ultimately I found after a research on the ChatGTP that you focus on your topic, and that's why I thought that let me talk about my topic and let me focus on that rather than to go for the debate. So orbital atherectomy, it's a old device, but now it has been changed with the new format, Diamond Bag 360. It's a single operator device, and you can see the crown, which is eccentrically moving. This is the crown. There are rotation speed buttons and everything is there. Wiper slide lubricant, the wiper wire, which is reasonably good for the maneuver. And it's an easy setup. We can do it with the 6 French catheter, and it doesn't take much time to deploy that. So this is the device with the crown. And it is basically 1.25 millimeter classic crown. And it does two things. One thing is rotation, and second thing is it orbits. So when it orbits, it covers the entire diameter of that vessel. Here it is 3 millimeter of the diameter of the plastic tube. So you can see it here, it rotates as well as it does orbit of the wall of that tube as well. So it does dual mechanism of the action. One thing is it does debulking, that is the superficial calcium which gets converted into the microparticles, and that reduces the bulking of the calcium which presents there. An important thing is it is a bidirectional mechanism, and it does the sending on both the way. And second thing is pulsatile force, which cause eccentrically mounted orbiting, that is a pulsatile, that gives a pulsatile forces, and that breaks the deeper calcium. So you can see it here that, that this is the debulking of the superficial calcium. The microparticles which gets converted, which are approximately of 2 micron in size, and that gets that are even smaller than the RBCs and all. So that will get cleared easily from the circulation. And this is the pulsatile force because of the orbiting nature of the device, and that gives cracking of the deeper calcium. You can see the deeper calcium gets cracked here. And this is the mechanism you can see here. So healthy tissue remains safe because of the differentiating features of the device. And you can see the debulking of the superficial calcium, and you can see the cuts or the cracks of the deeper calcium as well. And at the same time, blood and saline flow continuously throughout the treatment. There is no obstruction of the flow or the blood, and that will be very helpful for prevention of the slow flow, and the distal perfusion remains as it is. So atherectomy device, if we see two devices, what we use clinically right now. So rotational atherectomy, it is a unidirectional front cutting, as we all know that. And That's the reason sometimes there is a risk of the burr entrapment. While the orbital atherectomy, it is bidirectional, and at the same time, it does sending as well as cutting the deeper calcium as well. Second important thing is that we can create the lumen of that rotational atherectomy burr size only. We can't increase the, gain the lumen bigger than the burr size. While in orbital atherectomy, it is 360-degree rotation of that, and that's why it does sending of the calcium as well as it does the cracking of the deeper calcium as well. And third important thing is that there is a chance of the slow flow with the rotational atherectomy, which is not there with the orbital because it allows for the continuous flow of the blood and the saline while doing the orbiting. Second important point is guide wire bias, which is there with the rotational atherectomy sometimes because of the curved curvature of the tube or tortuosity of the artery. You can see it here, the curved plastic tube here. You can see the rotational burr is getting biased to the one side, so the other side may be remain untreated, while at the same time orbital atherectomy, because of the 360-degree of the rotation, it gives the full coverage of that part as well, and there is no specific bias. You can see it here in the 2 mm glass. You can see the crown is crown is affecting the glass tube wall as well, so that gives the treatment to the deeper calcium as well. And we have lots of trials to support this thing. Orbit 1, Orbit 2, we are the part of the Orbit 1 trial. Coast, Eclipse, all these trials, Eclipse is undergoing right now. So all these trials and real world study with the large volume, almost 450, 500 patients from some of the centers in the US. And they have shown that almost 1,000 patient data has shown that there is less than 1% angiographic complications in the real world scenario. That means that the dissection, perforation, they are the risk factors or the complications with the rotational as well as orbital atherectomy. But with the orbital atherectomy, the dissection and perforation with the real world data is very, very low. It's hardly 1 to 2%. In fact, slow flow is less than 1%, and perforation and dissection is up to 1.5% in the real world data of those studies. Important things, as Dr. PKP sir has also mentioned, that we need to go slow with the orbital atherectomy. That is very, very important. You can see it here. Then when the speed is high, that will jump. The orbital device will jump. So you should go slowly while doing, while the burr is getting rotated, and that will give a maximum debulking as well as good therapy to the deeper calcium. And regarding the ostial lesion, it is very important to do the backward movement. So we have to do the glide assist to enter into the vessel distal to the lesion, and we need to sending the calcium with the backward movement rather than to do the forward movement, because when it orbits in the larger artery and it goes into the smaller vessel, it can create the dissection, the perforation. So this is one thing which we need to keep it in the mind when we are dealing with any ostial lesion while doing the OS. So as such, there is no head-to-head comparison, or there is no large data which shows any comparison with one device with the other device. But if you see this slide, which has been taken from multiple references, so rotational atherectomy is a rotating burr, 140 to 160 million rotation per minute. OA is 80 to 120, while IVL gives 80 to 120 sonic waves. Temporal vessel occlusion is there with RA and IVL, obviously it is there. With OA, it is less likely. Tight stenosis, again, IVL crossability is the issue sometimes. And in that situation, rotational atherectomy or orbital atherectomy is better. Wire bias is there with RA, not with the OA. Modification of the deep calcium is there with the OA and IVL. Probably it will be difficult with the RA and not possible. Procedural complications, wire entrapment, slow flow, dissection, perforation, nothing will happen with the IVL, and that's why it is very user-friendly. But with the RA and OA, if you are doing with the, if you are experienced and we are doing with the safe end, the complications rate are very, very low. Coming back to this case, very tight, 95% calcific lesion. That means that there must be huge calcium which is going, which is coming inside the lumen, and in that situation, I would like to go for the debulking therapy for the calcium. Though there is no imaging right now we have, but in that situation, I would say atherectomy device is better, and my choice will be OA because it is having better safety profile and better mechanism of action in comparison to the RA. And yes, obviously it is a single burr for all the things where we need to use a larger diameter of the vessels, and it can does the modification of the deep calcium as well. Thank you.
Thank you, Dr. Tejas, for this nice information about the orbital atherectomy. And again, this case was specifically mentioned by Dr. Kamal sir. For this patient is mainly two reasons. One is the TIMI-2 flow, specifically mentioned about the prevent no flow of the calcium debulking tools. And second is the negative markers. The patient is not MI. So these are two things we have to decide about the further management. The first thing, take-home messages are calcium is enemy, so we have to break the calcium or soften the calcium or drill the calcium before implanting a stent for better long-term prognosis. If we put the stent before breaking the calcium, then your stent can, ISR, stent thrombosis are very high. Second thing, intravascular imaging is very important in this group of patients to decide the eccentric calcium, concentric calcium, or calcium nodule. If you find calcium nodule, then it is a very difficult for intervention because high risk of perforation and dissection, so that we can decide by the IVUS or OCT. Both has advantage, disadvantage. OCT can assess the thickness of the calcium, but IVUS cannot. But however, IVUS is more useful for circumferential assessment of arc of the calcium. The third thing about the using of the whether orbital or IVL or the rotational atherectomy, of course, rotational atherectomy is proven for long term. However, it requires expertise and to use it. While the IVL is more user-friendly, the data long-term are same. And IVL, only thing we have to negotiate the lesion. If calcified lesion, IVL difficult to negotiate. Tortuosity of lesion or artery, IVL difficult to negotiate. Otherwise, IVL is a more safer tool than using the orbital or the rotational atherectomy. The rotational atherectomy, of course, is good because of it's faster and we can drill the calcium. However, limitation is a unidirectional. So osteal lesion, we cannot use the rotational atherectomy. While the orbital atherectomy is a very slow process, it takes longer time, more fluoro, more radiation for the operator. However, we can use bidirectional. So every tool has advantage, disadvantage. Eccentric calcium, we can use the scoring balloon or angiosculpt or the Wolverine balloon. So in this patient, I think we should try to use the intravascular imaging first and then decide if we can pass the IVL, IVL is good. Otherwise, we can decide the call of the orbital or rotational atherectomy. Thank you. Any other comments?
So one thing about the orbital, I would say, if you see, you have to, after every rotation, we need to check the angio. And if you feel any dissection, you should stop that. Probably the same thing for the rota as well. But orbital, it can, the intimal flap can come inside the orbit, which is very, very likely. So you have to be very vigilant. If there is a dissection, you need to stop that. You have to remove it.
The orbital is very user-friendly, means the very small machine can carry on anywhere in the state, like one machine. While the rotational, you require the nitrogen tank and everything, so it's more likely. But if you depends upon the patient to patient, I think the osteal lesion, you have to use the orbital atherectomy and less tortuosity. Again, this 1.2 fiber. So deeper calcium is more useful with the orbital rather than the rotational atherectomy.
Orbital atherectomy, if you have dissection, then you should not use orbital atherectomy.
Yeah.
Rotational atherectomy still you can use
it,
if there is dissection. Secondly, if you are treating instant restenosis due to heavily calcified lesion, you should not use orbital atherectomy. Okay. And you are treating osteal lesions like out osteal lesion like RC osteal lesion, then you should never use a forward running. Always backward. Is good, because otherwise you can create the dissection in aorta with orbital atherectomy.
So yes, sir. So
but rotational atherectomy you can use only for the out osteal lesions safely. Basically, you have to think of the three factors: device crossability, debulking efficiency, and cracking efficiency. Device crossable device, I think retardator is the best device. For cracking efficiency, I think IVL is the best device. And for calcium debulking, I think orbital atherectomy is the best device.
Many times you have larger diameter vessels. In that case, rotational atherectomy would use 2 bar, 1.5, sometimes 1.75, or 1.25 to start with. Well, orbital has only one size bar. We can have double directional as well bidirectional. So that is advantage of using orbital, larger diameter with a heavily calcified vessel.
Sir, just one moment. We see so many patients who have, say, superficial as well as deep calcium. So, point term has been raised that it is rotatripsy. So, when you have a circumferential arc of calcium and you have superficial eccentric calcium, do rota and as well as use the IV.
Perfect.
If you have the facility of the
Correct, completely agreed. So a lot of time you might have to combine both. There are patients where you have to combine not only both, then maybe you will have to post-stent, you will have to also use OPN balloon. So sometimes all three may be required and calcium may not go. So orbital is something that's going to be slightly different in the sense. Only problem is cost. So compared to the the old one, the old rota that we still continue to use, the classic one, is still 50,000 cheaper compared to orbital. So orbital is like 1 point.
Same as IVL, no? Same as IVL.
So it is same as IVL.
Especially what Sir said about critical calcium lesion, when you cannot use the IVL, then you initially use rotational atherectomy. And then if you do imaging again, if you find imaging, this still residual calcium is there. And if you think the stent won't expand, then you use the IVL after doing rotational atherectomy to use rotatripsy to get better outcome in the result of the long-term stent.
I think there is a beautiful example, I saw it one of the slides, where it is like breaking a mountain on the tunnel. So if you just want to chop off the top of the mountain, anything would do it. Rotational may carve it out like this. Mountain top will be chopped off by rota. But if you do IVL, you crack mountain into small sub-mountains and then you slough it off. So then you have not only addressed the lumen, you've also addressed the part of the base of the mountain. So mountain of the calcium, that's where, so it all depends if it's a nodule or if you're dealing just with a chunk, which I think was covered in the slides that Dr. Prakash Virpari was showing, then probably the modalities will change. And as Mamas was speaking, he said that you need to first image to know the difference between the two. If you image, things are going to be much easier to choose, provided, of course, you have that much of budget. You image, you rotablate, use an IVL later on as well, then do a stent and then do OPN and then again do image and then end the plasty, right? So that's how most of the times we end up.
IVL is the best as the best device to treat the deep calcium. It is most effective for concentric lesions. Eccentric lesions and nodules, I think IVL is less effective.
So no flow, what do you think better for rotational or the orbital? For no pre
I
and
think
no flow?
safest device is IVL for all calcified lesions. Orbital is the second safest device. Rota is the highest complication rate.
There was a small study which compared head-to-head rota as well as OA. And what they found was like the width of the calcium and the depth of the calcium, the better penetration with OA with the depth of the calcium. So OA was superior as far as the depth of the calcium was concerned. As far as width was concerned, both were same.
Because the orbiter works on the centrifugal motion. It's not only unidirectional, it's orbital motion also. That's why it's a deeper debulking.
So we had the same question, whether we have a randomized control data sets to compare IVL with his rotational atherectomy. There is no benefit in any documented trial, whether you look at Rota shock trial, which was one of the largest trial, which again probably Mama's touched upon. It was non-inferior to rotational atherectomy, whether you talk of MSA, stent expansion, and it's hence the reason that it got the approval. The Rota shock trial is the one trial. That's how it got approved in European markets for the therapy. So basically, as of now, it's primarily because of the non-inferiority design of the trial. It was not statistically significant. It had to do 85% of the cutoff of the superiority margin, and it was within 85% of RA. So statistically speaking, it's non-inferior to RA.
But the most important is you should be able to cross with the IVL. Because when there is heavily
should be able to
calcification,
cross.
you will not be able to cross with the IVL.
It will not
so you
cross.
can't use it.
So Dr. Harin got it fastest. Well, request Dr. Harin to come and collect the prize from our chairpersons for that quiz. Dr. Harin.